an antibody that, isn't helpful anymore. Evusheld right now still seems to be helpful. Hopefully it will continue to be helpful against whatever's coming. But obviously we'll see, and we'll get guidance from the CDC and the FDA about whether it makes sense to redose with Evusheld, in the next few months. There's a question here about Cal 101 trial, which began in 2020. This is a very study-specific question. The short answer is we can continue. We have the option of continuing. So we'll talk about that in an appointment. Cal 101, just for people's information, is an antibody to treat a related condition called amyloidosis. It's another antibody. When amyloidosis it's a plasma cell disease that's related to myeloma. For patients who just have amyloid, the abnormal plasma cells in the bone marrow, instead of like completely overgrowing the marrow and causing bone lesions and low blood counts, the problem is not that the cells grow so fast, but that they make a dangerous misfolded protein. They're light chains, which is the part of the antibody, the M protein that myeloma cells make. The light chains that amyloid plasma cells make misfolds, and then it gets sticky and it forms clumps and strands and globs of protein that get deposited in organs. And the symptoms patients with amyloid has to do with organ injury from these protein deposits. So historically, the therapy for these patients has always been kind of built off of myeloma therapy. We're still targeting the plasma cells with sort of the anticipation that, if you wipe out the plasma cells, you shut off the production of these dangerous misfolded light chains, and organ function gets better over time. What Cal 101 is an antibody that actually targets these protein deposits. So instead of an antibody like Darzalex or daratumumab, which targets the plasma cells, you're targeting the product of the plasma cells. And in the study that Judy referred to, we're simultaneously targeting the plasma cells with anti-plasma cell therapy and the protein deposits the plasma cells made with anti-protein therapy. With the hopes that organ function recovers more quickly if you can sort of clean up the amyloid deposits in the organs. So yet another application of antibody therapy.
Dr. Zonder, I have a question here.
Yeah.
In your research, have you ever found a relationship between the typical myeloma drugs such as Pomalyst, Darzalex, dexamethasone, and arthritis, particularly in the hands, causing finger joint swelling and pain?
Short answer, no. I would actually say that more commonly, honestly, we've, most patients, who have arthritic symptoms, there aren't very many benefits or upsides to dexamethasone, but one of them is that certain aches and pains do tend to be better on dex containing regimens. So my patients with bad COPD and asthma and my patients with bad arthritis sometimes actually really like the dex. I'm not gonna, I can't possibly look at everybody's faces on the screen and pretend that dex is an easy drug. So I'm not saying that. I'm just saying that there are some upsides to it. It is a hard drug for most people. But no, joint redness, joint swelling, induction of arthritis is not a common side effect of any of the drugs that you mentioned or others. So no, I can't really say that I have. I do have patients. I mean, for some patients, peripheral neuropathy can have a crampy, achy sort of aspect to it. It's not always burning and tingling and numbness. Sometimes it feels like cramping and aching. So there is that. And also some drugs, notably Revlimid, lenalidomide and pomalidomide, can be associated with legitimate muscle cramps. And so, and as can Zometa, or any of the bone strengthening agents which lower calcium levels, can also cause muscle, cramping and spasticity. If it's related to those bone strengtheners, that can be helped with calcium supplementation for the several days after administration of the med, and for Revlimid related, IMID related muscle cramps, treatments are variable. Patients try calcium supplementation, magnesium supplementation, Epsom salts, pickle juice. Those are the things that a lot of patients try before we try actual muscle relaxers.
So
pickle juice is probably just electrolytes. I mean, honestly, it's probably just the salt, in it. There is mustard seed in most pickle recipes, and I don't know if it's the mustard seed or not, but little shot of pickle juice. Some patients also tonic water. I mean, if you don't have any heart rhythm issues that preclude getting quinine, tonic water is a helpful thing for some patients. I have a lot of patients who get nighttime muscle cramps and they just drink a glass of tonic water before bed. Mix responsibly, but it's the quinine. So you actually can mix it with juice or other things and still get the quinine. So,
So it's 10:01. We're going to be winding down. I think that there's one question that didn't get answered. Correct me if I'm wrong. It was from Hale. Is the high cost of CAR T justified if the duration of response is only averaging about a year?
Hal, I will answer that with another question, which is the high cost of any of the meds we're using justified, period? I mean, it's myeloma therapy. Myeloma is one of the most expensive diseases in the world to treat. And that's only becoming more and more true as patients live longer. The financial stress on patients and on the medical system in general is increasing, with a growing number of oral drugs. There's more cost to patients, more financial toxicity. And a quadruplet regimen that works for 5 years, it turns into a pretty pricey, millions of dollars of therapy when things are, measured in years like that. CAR T cells cost a few $100,000, like $300,000 to $400,000. For contrast, an auto transplant costs something in the neighborhood of $125,000 to $150,000 now, I think. So the question is it worth? Is it justified if all you're getting out of it is a year? I think that is a big question that insurance payers are asking. I think what I would say is the jury should still be out on this. I think that we will see longer responses than that when we use it earlier. And so then it starts, then your comparator ends up being, is CAR T cells as second or third line therapy where maybe you get 2 or 3 or 4 years of response. How does that stack up compared to 2 or 3 or 4 years of, Rev and Dara as maintenance? It becomes a more comparable comparison. The other thing is that most therapies would cost honestly a few $100,000, a couple $100,000 at least, if they work for a year. So when you think about what would Darzalex cost, what would Expovio, selinexor cost, what would Blenrep, belantamab cost, if you're in the minority of patients who get a year or a year and a half out of those therapies as fourth line treatment, and the answer is a lot, at least a couple $100,000. So it's not, CAR Ts feel out of this world, but I'm going to go back to that first question I asked you, and just I think, we have to be honest that all the therapy is kind of out of this world in terms of cost at this point. Hopefully with generics coming, that may improve a little bit.
So Dr. Zonder, just very quickly, I just wanted to ask, so no COVID booster is needed if you're up to date with Evusheld.
That's right now, that's not the recommendation. I view them as complementary therapies. For immunocompromised patients, the booster recommendations keep evolving. I think we're up to a 5-dose course now for immunocompromised patients. The primary course is now 3 doses, and then and based on how far into this we are at this point with the frequency of boosters, we should be at 2 boosters beyond the 3-dose original course. Most of my patients are not at 4 doses yet, let alone 5 doses. So there's a lot of variability. I mean, most patients have been boosted at least once from what was at the time the sort of the original standard of 2 doses. Most of my patients have had at least 3. Some have had 4. Almost none have had 5. And frankly, the majority of patients in my practice who've had 5 are the ones who were desperately trying to induce a response after failing to respond to, say, a 2 or 3 dose course of one mRNA vaccine. They switched to the other and got a pair of doses of that vaccine, the other one, hoping to get a response. So it is, I think the reason to think about getting vaccinated, Mr. Trudeau, is, we don't know, we don't have certainty that Evusheld will continue to be effective, right? If a strain comes out that is, not neutralized by Evusheld, the immune response may be a bit broader than Evusheld, and also the Evusheld really is designed to prevent COVID by giving you a sort of a fixed dose of antibody, but a vaccination, if you respond to it, hopefully permits your body to have sort of that reactive response to an infection, and will drive a robust immune response to sort of shut down an infection. So I'm still recommending, and I think in the FDA and CDC, they're still recommending that they're complementary to each other. One's not a replacement for the other.
Okay.
Yeah.
Okay.
Yep.
Well, it's 10:08. Does anyone have any other questions before we log off?
Dr. Zonder, is elotuzumab in that group of drugs you talked about before?
Yeah, ELO is an antibody. It targets something called SLAMF7. It does not have meaningful single agent activity. Karmanos was actually one of the lead sites in the original first in human study where we were figuring out the dosing of ELO way back when. We published that in 2012 or 13, and there were basically, we never hit dose limiting toxicity no matter how high we raised the dose, including doses well beyond where we sort of saturated the target, right? If you think about what antibodies do, they're binding to a specific something on the myeloma cell, and there's only so many of those target molecules to bind, and you can actually saturate it where there's nothing left to bind because it's all filled up with antibody. And you can dose ELO well above that level and still not hit any sort of limiting toxicity. So it's a fairly benign drug, but also we had like 0 objective responses on that study. We had a few patients whose disease stabilized. There are case reports of patients who've responded to ELO by itself, but those are few and far between. Those are like a handful of patients. So the way ELO is used as an antibody is it's used in conjunction with drugs in the Revlimid and Pomalyst family, the IMiDs.
Yes.
It's approved in combination with Revlimid and in combination with Pomalyst in relapsed disease. There was an upfront study of Rev plus or minus ELO that actually wasn't positive. So it doesn't seem to be helpful in all settings. I personally think that the sort of like, we have some positive studies, we have some negative studies. My feeling is what ELO adds to Rev and POM is probably not as good as the best studies and not as bad as the worst studies. These are all, there's something called regression towards the mean. What you have is you have studies sort of on both sides of average. And if you just sort of just add it all together, there's probably truly a modest improvement in outcomes. It doesn't change the response rate very much, but it seems to extend the duration of disease control a little bit. When ELO is a great example of coming back to that question that was asked before about single agents versus doublets and triplets. Like if a patient's never had ELO before, even though it doesn't add a ton in most cases, if you have a patient who'd otherwise just be giving Pomalyst or Revlimid to, it makes an awful lot of sense to add ELO, in my opinion, because the toxicity is quite minimal. But yeah, it's an antibody therapy.
Oh, thank you. Because my husband started with Rev and Dex and he got blood clots. And then he went to Rev, Dex, and Velcade. Nothing lasted very long. He's now on POM, Dex, and ELO. And it's
Right.
been over 2 years. He's under good control with light chain. So
yeah, the study that led to the approval suggested that adding ELO actually beefed up the response rate to Pomalyst quite a bit, but that's honestly pretty unique. That study, the results were the results, but if you look at all of the results of all of the Revlimid studies that have been done with ELO, in those studies, it didn't really dramatically increase the response rate. So my working assumption is that the effect on response is modest. I have plenty of patients on POM and ELO who have gotten great mileage out of it. So I'm not knocking ELO. It's important to have appropriate expectations for the antibody. ELO is not the same as isatuximab or DARA, which targets CD38. ELO is also not the same as belantamab, which targets BCMA. It's less toxic than belantamab because of that eye problem that we mentioned before, but it is definitely does not have even close to the same kind of single agent activity.
So when things are starting to rise in the light chains again, probably that'll be something that drops off and something will replace it.
Yeah, I mean, it's hard to predict what's going to happen, but if on a 1-3 drug combination, the response starts failing, then you start looking at what other combinations could you have, and it always comes down to a question of, do you swap out drugs or do you just overhaul everything and just replace those 3 drugs